our respiratory disorders, and our cardiac disorders. So there's a lot of content in here. So we have 2 separate PowerPoints this week. So in class, we are going to go over the condensed PowerPoint and hit the highlights of the important things that you need to know. The other PowerPoint that is in your week 6 information is kind of like a self-study in-depth PowerPoint. So if you struggle with respiratory or cardiac disorders, that PowerPoint is going to be really helpful for you. Has a lot of extra information about the respiratory disorders. And then for all of the cardiac disorders, it also has little videos that show you a visual of what's changed with the anatomy. So if you're a person that's a very visual learner, that extended PowerPoint is going to be really, really helpful for you to help figure out the cardiac disorders, especially. So today we're going to focus on the condensed, hit the highlights, the important information, and then we'll have time to do our full Kahoot today. Just like last exam, our results will be posted on Saturday. So we'll let everybody test. We'll go over and make sure that all the questions were fair, and then we will adjust scores as we need to. You guys will notice you got one extra question back on your last exam. After meeting with students, we realized there was one that was worded a little unfairly. So you guys got an extra 2 points on your last exam that was different from your original grade. So without further ado, we will start our respiratory disorders. So when we start with the respiratory system, we obviously have to talk about ventilation. And that is the process of breathing air in and out of our lungs. It's going to be affected by our musculature, our intercostal muscles, our diaphragm, our ribs, also going to be influenced by the receptors that stimulate our breathing and the responses that we get from our brain. So our lungs start developing during the fetal process, and at about 24 weeks gestation, we begin to produce surfactant. And that is a chemical that keeps our alveoli from completely collapsing. So it allows them to open back up. And we know that our fetus is reliant on the placenta for circulation, and they're not actually breathing air. So the gas exchange all happens through the placenta. And then by 35 weeks, we really should be able to function outside of the uterus and be able to be reliant on our lungs for breathing. When we're looking at being ventilated for a prolonged time, so being on a ventilator, respirator, or having that extra support to breathe, it can cause chronic lung disease because we're making the lungs work a lot harder than they're used to. So we can cause high levels of CO2 in our blood and low oxygenation. Those two together are going to stimulate our brain that we need to breathe more. So as our CO2 rises and our oxygen falls, our brain's going to say, we need to increase our respiratory rate so that we can catch up here and bring that oxygen back up. When we have chronic lung disease, our receptors get really used to that high CO2 level, so they don't stimulate the lungs to breathe faster. So we can have a decreased respiratory effort, and that can eventually lead to respiratory failure if it's not treated. For our respiratory disorders, we have a couple different ones. Nasopharyngitis is the big umbrella term for things like colds, allergic rhinitis, which is your common allergies, and then upper respiratory infections. So we need to remember that coryza is our common cold, allergic rhinitis is our normal allergies. And then when we have upper respiratory infections, it's really important that we are encouraging hydration. So we're going to let our kids take small amounts of whatever we can get them to drink. So whether that's their favorite juice, or if we can just get them to suck on a popsicle, if they're a water drinker, whatever they will drink, we will give it to them to keep them from getting dehydrated. For acute pharyngitis, this is going to be either from a viral infection or strep throat. We need to make sure that we get prompt treatment and complete treatment so that we don't end up with these complications that are listed here. So things like rheumatic fever, glomerular nephritis, ear infections, meningitis, osteomyelitis, pneumonia, all of those we want to avoid. Sinusitis, so our pediatric population do not have their sinuses fully developed until they're 18. So it's really easy for their sinuses to get infected just because they're not fully developed. So anytime we have an infection in our sinuses, then we are going to require antimicrobial therapy to treat that. And then croup is that barking cough that everybody is pretty familiar with, that very, very traditional barking cough. The extended medical term for croup is going to be laryngotracheobronchitis. That's an important one to remember. And these kids are going to have an inspiratory stridor. So every time they breathe in, you're going to hear that high-pitched squeal as they're breathing in. And then they have that barking cough throughout the day. Anytime they're crying or agitated, that cough is going to get worse and that stridor is going to get worse. So we recommend placing these kids either in a croup tent or providing cold water humidifier for them. So that cold water will help to relax their airways, and the humidity that they get will cause vasoconstriction. So their airways will open and they'll be able to breathe a lot easier. It's really important that we don't give these children sedatives, no opiates, no sedatives, because that's going to decrease their respiratory drive and make their brain not respond to breathing. So what do we want to include for our parent education? So we definitely want cold water humidifier so that we're relaxing those airways. Opiates are going to decrease our respiratory drive. Aspirin, if we give aspirin anytime we have flu-like symptoms, we can cause Rye syndrome, so that needs to be avoided. And then we want that cool water to promote that vasoconstriction so that everything opens up nicely for us. So epiglottitis happens very abruptly. We get swelling in the tissues above our vocal cords, and it's commonly caused by Haemophilus influenza. These kids are going to insist on sitting upright. They're going to be leaning forward with their mouth hanging wide open, and they're just going to be drooling incessantly. They're not going to be able to swallow their own saliva because of the swelling in the vocal cords. They're also not going to be able to cough. So it is extremely important that we never examine their throat with a tongue blade or put anything in their mouth until we have a tracheostomy set at the bedside. So these kids could have a laryngospasm if you put anything in their mouth, and then their airway will completely shut down and they will not be able to ventilate themselves. So we need to have another form of alternate airway before we do a throat exam. And that these kids are medical emergency, obviously. For bronchitis, that is going to be a viral infection of our small airways. In infants that are 6 months to 2 years old, we see this obstruction that leads to atelectasis, so that difficulty in breathing. Our lungs don't fully open and close like we want. They also have an increased respiratory rate and an increased heart rate, and it can make them really irritable and lead to dehydration. We see incubation being about 4 days with bronchiolitis or RSV. And if they're hospitalized, they will be in droplet isolation, and hand hygiene is going to be essential to not spreading this across the entire hospital. So these kids will need things like supplemental oxygen. A lot of times they need IV hydration because their respiratory status isn't stable enough for them to be able to take things by mouth. They'll also need antiviral medications to help with fighting off this respiratory virus. And then we see pneumonia. So RSV is going to be one of the most common causes of viral pneumonia. And our symptoms are going to vary with pneumonia depending on how old the child is and what organism is responsible for causing pneumonia. But a lot of times we get a dry cough, a fever, they've got tachypnea. Their respirations are going to be shallow because it's painful because of how much they're coughing. They can also be listless, have a poor appetite, and if they have unilateral pneumonia, they tend to lie on that affected side. We can confirm pneumonia with an X-ray, and we can also look for an elevated white blood cell count. We can do cultures to figure out which organism is causing the pneumonia. And then it's really important to keep their oxygen saturations above 90%. When we're looking at tonsillitis and adenoiditis, one of the things that we need to be on the lookout for after surgery is frequent swallowing, especially while the child's sleeping. That's going to be an early sign of bleeding post-operatively. We also want to avoid things like milk and milk products because that could coat the throat and cause the child to constantly be trying to clear their throat and irritate the operative site. Also, don't give things like red popsicles. That's going to mask bleeding. So no red juices, no red popsicles, no milk products afterwards. For asthma, it's just like adult asthma. So we've got obstruction that's most severe during expiration. So when they're breathing out, they may be coughing, may have wheezes, difficulty breathing. We're looking for signs of respiratory distress. So flaring of the nostrils, using their accessory muscles. So using their belly muscles or using the muscles in between their ribs to help them breathe. And then you may see orthopnea where if they stand up, they're going to get dizzy. Or if they move quickly, they'll get dizzy. Status asthmaticus is going to be very similar to status epilepticus. So it's severe respiratory distress that's not responsive to medication. So that's going to be including our racemic epinephrine that we use or amniofilin. So just like status epilepticus, status asthmaticus is going to be a medical emergency. We're probably going to need an advanced airway for this child to get them to be able to relax and return to normal breathing. So here we have our first critical thinking question. We have an 8-year-old with a history of asthma, lives with mom and younger sister. We're looking at the home environment and learn that the family is in a townhouse, has a cat and 2 dogs, mom smokes, and the child shares a room with younger sister. They've got carpet in the house. How do we modify the home environment to get better control of her asthma?
One of the things we should do is make sure that the parent, if they continuously like smoke, they should be smoking outside away from their child. And with that, the odor still kind of lingers on their clothes. So making sure that you're washing and cleaning clothes like properly, because smoke irritates all of that asthma.
Yeah, good job. Yep. If you're going to smoke outside, put on a jacket or something that you can take off before you're near the child, so you're not transferring that on your clothing. What else?
We can vacuum frequently, like with the pet hair and everything.
Yeah. Making sure our carpet is free of dust and mold and pet hair and dander. What else could be a risk for collecting all of those things?
I know they have things that like clean the air. It's not like a humidifier, but do you know what
Yes,
I'm talking about? It
a
like
HEPA
filters
filter.
the air.
Yep,
Yeah.
a HEPA filter. Yep. So definitely, HEPA filters are great. We also want to make sure that we're keeping like any stuffed animals, any upholstered furniture, fabric curtains, all need to be cleaned regularly. Mattresses and pillows are another big source. They're just collecting of dust and dander. What about the air would help with asthma? What can we do with the air?
Steam air can help.
Humidifier.
A humidifier, yep. So keeping the humidity a little elevated will help to keep those airways nice and relaxed. If we can take out the carpet, that would be great. Making may or may not be possible. And then ideally, no pets, honestly, for asthma. But just making sure that pets aren't in bed with the child, especially making sure they're not right up in their face all the time. Good job, guys. So next up is cystic fibrosis. And the important thing to remember about cystic fibrosis is this is a multi-system disease. So it touches a little bit of everything. But the main issue is these thick, really, really viscid secretions. So those secretions obstruct our airways. They also prevent our digestive enzymes from flowing into our GI tract, so we don't absorb food well. That leads to bulky, foul-smelling stools that are going to be frothy because of all the undigested fat in them. We also see a loss of electrolytes through their sweat, and that will cause them to have a very salty skin surface. And then they are also at risk for infertility due to those really thick secretions. They're going to decrease sperm motility. And then in females, you have thick cervical mucus that inhibit the sperm from making it to the fallopian tubes. So we see our respiratory, our digestive, our skin, and our reproductive systems are all affected by this disease. So when we are teaching parents, we need to help them with diet modifications. So these kids lose a lot of sodium in their sweat, so they need to take in a lot of sodium to help replace that. They also need a lot of protein to meet their nutritional requirements for energy because they're not able to absorb the calories that they're getting from fat. So protein is going to be your big source of energy for them. They will also be on pancreatic enzymes with all of their meals. And they'll have a lot of breathing treatments to help with those secretions and opening their airways so that they can breathe well. We'll teach parents about postural drainage. So teaching them how to move those secretions through the lungs so we can get that junk out. And these kids are going to tire very easily. If you think about breathing when you're sick and you are all congested, you know it doesn't work well and you can't do activity like you're used to. So if you think about that tenfold for these kids with cystic fibrosis, you know they need a lot of rest periods, short bursts of activity. They're going to be followed very closely by their medical support team. And then parents will also need emotional support for dealing with chronic long-term illness. So what are some of the goals that would be appropriate for a child with cystic fibrosis?
Increase water intake to help loosen up the thick secretions.
Yeah. You guys are on it. You guys nailed it. So they're going to have increased nutritional demands rather than decreased. Because they don't process things well, they're going to need a lot more exposure to food to have a chance to get a little piece of it. Obviously, we want to minimize our pulmonary complications because they're kind of what's driving the bus here. Family's going to need a lot of support, and we're really going to be working on promoting that growth and development as much as we can. Next up is bronchopulmonary dysplasia, and this is commonly referred to as BPD, and this is where we have thickening of our alveolar walls and our bronchiolar epithelial. So this is going to be really common in our premature infants or kids that have been exposed to long-term ventilation. So on a ventilator for a long time, or they've been on CPAP for a long time. So that's where our preemies are going to be most at risk. And then SIDS, or sudden infant death syndrome. The important thing is to remember that it peaks between 2 and 4 months of age. So this is an unexpected death in a healthy infant. They can happen anywhere between 2 weeks and the first year of life, but typically peaks in that 2 to 4 months. So this is why we really, really promote the ABCs of safe sleep. Do we have questions on respiratory? Okay. We will go ahead and move on to cardiovascular. So this is our first system to function in utero. So we have different types of congenital heart diseases, and these can be caused by a lot of different factors, whether it's a genetic disorder, if there's something wrong with mom, or environmental factors. It's not a problem during pregnancy because we have that fetal maternal circulation. So we're not reliant on the infant's anatomy to be able to keep our circulation going. Once we're born, we're reliant on the infant circulatory system to provide for all of our oxygen. So that's why we see a lot of these problems that crop up right after birth. We have 2 different categories. So we have cyanotic defects, and those are ones where we don't have enough oxygen perfusing, so we turn blue. So cyanotic are defects that make you turn blue. Acyanotic, we're still getting oxygen pumped out to the body, so we're going to stay pink, but we've still got something abnormal going on. So cyanotic's blue, acyanotic, we stay pink because we still have some oxygen going. We also have different types of lesions. So some make more blood go to our lungs, like ASDs, VSDs, and PDAs. Some of them are an obstruction. So we've got a narrowing or a kink that's preventing blood flow. That's going to be our coarctation. And then disorders that keep blood from going to the lungs, that's going to be our tetralogy of Fallot. Then we have ones that the blood just gets all mixed up together. So we've got unoxygenated and oxygenated blood all mixing together, and we tend to stay pink defects, but hypoplastic left heart syndrome and truncus arteriosus. So you've got that heavy mixing of oxygenated and deoxygenated blood there. And then we have shunts. So a lot of these defects will have a shunt associated with them. And that is going to be an abnormal opening where blood's flowing. It's always going to flow from areas of high pressure to an area of low pressure and take the path of least resistance. So you can have a left to right shunt, you can have a right to left, or you can have a mixed where it just kind of goes back and forth in between the two chambers. When we're looking at treating children with congenital heart disease, looking at our overall symptoms, we're going to have an increased pulse and respiratory rate, trying to move oxygen through the body faster. They're going to be at risk for growth delays. So their constant level of increased respirations and pulse are going to eat up all their nutrition so that it can't be used for growth and development. It's just going to be used for survival. They have a lot of difficulty breathing, dizziness when they're moving, fatigue, and they're at high risk for upper respiratory infections because the cardiac and the respiratory system are so intertwined. So these kids will likely not be able to compete in competitive sports. They're going to need a lot of help with nutrition. They're going to need very high calorie, small, frequent meals so that they're not getting tired out while they're eating. And then they're going to have to be careful in high altitudes and cold environments, things that could cause respiratory distress, because they're going to be at a lot more risk with that cardiac disorder. So first up, we're going to talk about coarctation. So this is where we have a kink in our aorta. So if you think about the aorta as a garden hose, you know, when your garden hose gets kinked or twisted, the water doesn't go through. So that's exactly what's happening in our coarctation. We've got a kink in the middle and the blood can't flow through. It just runs into the wall. We can diagnose this with an aortogram, and that's going to show us that narrowing in the aorta that we're looking for. One of the telltale signs of this is having high blood pressures in our upper extremities and low blood pressures in our lower extremities. So if you did 4-point blood pressures, you would see a difference between your upper and lower extremities because we've got that kink there, so the blood's not making it to our lower extremities. If it goes untreated, we end up with hypertension, we can have congestive heart failure, and then we can also have infective endocarditis, so an infection in our cardiac muscle. Tetralogy of Fallot is going to be a combination of 4 disorders, and this is going to prevent enough blood going to the lungs. So we have stenosis or narrowing of our pulmonary artery, and that's going to decrease the blood flow to the lungs. We have hypertrophy of our right ventricle. So our right ventricle is going to enlarge in size and be massive because it's going to be working so much harder to pump the blood through that narrow pulmonary artery. So because it works so hard, it's going to get big and beefy. Then we have dextroposition of the aorta. So our aorta shifts over to the right and blood from both ventricles enters it. So that's where you get that mixed blood flow. So you're getting oxygenated and deoxygenated blood that are both going through the aorta. And then the last thing that we have is a ventral septal defect. So it's going to be a hole in the wall between the lower two chambers. One of the things that we see with these kids is these TET spells, or the paroxysmal hypercyanotic episodes. And they typically occur during the first 2 years of life, and the child will suddenly turn blue, have severe respiratory distress, weakness, and they can pass out. It can last up to a couple hours, and afterwards, they're going to be really lethargic and sleepy. So the two things that we can do for this child is, if they're an infant and they're too young to be mobile on their own, we're going to pull their knees up to their chest. So this is going to force the blood from the lower half of their body to return through the heart to be oxygenated. So we're using that abdominal pressure to help return blood flow so we can resolve that TET spell. In older kids that are mobile, you're going to see them playing and they'll be carrying on, and then all of a sudden they're going to squat. And they're doing that same thing. So that squatting mechanism for an older kid is that same knee chest reaction, trying to return blood flow to the heart. Do we have questions on that? That one's kind of a complicated one. Okay. So we're going to practice a little bit. We've got a 1-year-old boy who attends daycare and is diagnosed with tetralogy of Fallot. We kind of talked about what the condition is. What do we need to make sure that the parents tell the child care staff? What do they need to know to be able to take care of him?
They need to watch for like signs and symptoms like difficulty breathing, um, like discoloration of the skin, like it's turning blue.
Mhm. Yep. Watching.
Is that the one where they're breathing from their, like you can tell from their abdomen?
You can see that in pretty much any cardiac or respiratory disorder where they're belly breathing.
Okay.
That's a
Okay.
compensatory mechanism. Yep. Yeah, proper positioning if we have a TET spell. So if he's not in a squatting position, pulling his knees up to his chest to return that blood flow. What are we at more risk for because we have a cardiac defect? Are we going to have the same energy as our peers? No.
No, you'll be fatigued.
Yep, we're going to fatigue really easily.
So then they would also have a growth problem too, because like you said, all their energy is going into breathing and trying to push output, so
Yep.
they wouldn't grow as well.
Right, exactly. Yep. So we're working on those essential functions to stay alive. So we're not going to be growing as well. So we're going to be a lot smaller than our peers. We can also see that just general increased work of breathing or difficulty breathing. And that can cause us to be cyanotic. We can have clubbing in our fingers and toes. We also can see things like polycythemia. They're going to be iron deficient a lot of times because we're really focused on preserving life. These kids are they're going to have open heart surgery at some point. And a lot of times it's going to be a staged approach. And usually after open heart surgery, they do well. and they will need to be on antibiotics before surgery so that we don't end up with having any sort of an infection in our heart muscle. They're going to be at risk for a lot of upper respiratory infections, frequent respiratory infections. That's just going to be their normal MO because of the fluid shift. Okay, moving on to congestive heart failure. So this is the signs of congestive heart failure are going to depend on which side of the heart is affected. So if the right side of the heart is affected, it's responsible for moving the unoxygenated blood into our pulmonary circulation. So if we have a failure, it's going to result of backup of the blood into our systemic venous system. The other side, our left side, is moving our oxygenated blood from our pulmonary circulation into our systemic circulation. So if we have congestive heart failure, it's going to result in a backup of blood into our lungs. No matter what, we want to make sure that we are clustering our care, so we give them prolonged periods of being undisturbed. If they wake up, we're going to feed them early. We're not going to wait until our scheduled time. We're going to maximize their awake and alert time. We're going to do small, frequent feeding so that we're not causing fatigue. And we might need to give supplemental oxygen to help with that difficulty breathing. We are going to be giving medications to help with congestive heart failure, making sure that we're checking for safety doses. And we are going to constantly weigh these kids. They're going to need a daily weight because that's going to be one of those signs that our medications are working or they're not. So we can adjust our medications based on the child's change in weight. So if we have a sudden increase, we know that we're not getting enough fluid off of this child and that they're probably going to need an increase in their medication to help support them. If they're suddenly losing weight instantly, then our medication might be too high and we might need to decrease our dose because we're taking too much off of them. So really paying close attention to our eyes and nose and doing those daily weights. Rheumatic fever is going to be an autoimmune disease, and it's a complication from an untreated group A strep infection of our throat. So untreated strep throat can lead to rheumatic fever, and this involves our joints, our heart, our central nervous system, our skin, and our subcutaneous tissues. So we can see inflammation in our heart. We can see inflammation in our joints, all throughout our joints, so that polyarthritis. We can have erythema marginatum, which is going to be a rash all over our skin. Chorea is going to be swelling in our joints, and then subcutaneous nodules. So they'll have these little bumps under their skin. Those are all going to be signs of rheumatic fever. We are going to give these kids penicillin to eliminate their strep infection and prevent this permanent heart damage that can happen. And they are going to be on that penicillin for a minimum of 5 years so that we make sure we don't get a recurrence of a strep infection. They're going to need lots of rest periods and relief of pain and fever. So we're going to use our anti-inflammatory agents. They're going to be on steroids to help with the swelling in their joints, and also aspirin for clotting mechanisms. When we're looking at systemic hypertension, in our pediatric population, we are really focused on nutritional counseling, weight reduction, and increasing exercise. So we're really going to be looking at if there's an underlying disease that's causing an elevation, and then making sure that we're promoting those healthy activities. So just like in adults, we can use the DASH diet. So we're doing low-fat milk products, lots of fruits and veggies, looking at lean meats, low sodium, avoiding those highly refined processed foods. They're going to need help with weight reduction, which we know in pediatrics, we typically increase their exercise to help with weight reduction, and finding that form of exercise that makes them excited, that they're willing to do. In our adolescent population, we need to make sure that we're telling them about the adverse effects of drug, alcohol, and tobacco on blood pressure, making sure they're staying away from those. So what are some of the modifiable risk factors for hypertension? What are things that we can control and change to avoid hypertension? Diet, yep.
Stress.
Stress. Limiting our salt, that's a big one.
Smoking, like physical activity, excessive alcohol consumption.
Keeping track with our blood pressure in a journal or a notebook.
Yeah, keeping track. Having an idea of what's going on. I think we said it already, but does a sedentary lifestyle help with our blood pressure?
No, probably getting exercise in the diet or
Yep.
a amount of exercise every day.
Yep, getting that increased physical activity. Good job, guys. The last thing we are going to talk about is Kawasaki's disease. So this is an illness with an unknown cause that typically presents after a viral infection. So we diagnose this solely based on the signs and symptoms. We don't have any specific labs that we can do to tell us that you have Kawasaki's, but the disease causes inflammation of the vessels throughout our cardiovascular system. And that swelling and inflammation can weaken the walls of our vessels. So we often end up with an aneurysm where we've got that big dilation in one of the walls of the blood vessel. And those can also cause blood clots to form, which can be life-threatening. So we really want to make sure that they're on aspirin so we don't get those blood clots. If they have aneurysms, we're going to be a little bit more aggressive and we're going to prescribe Coumadin or warfarin. And the signs and symptoms are going to be kind of what you see along the bottom. Those bright red eyes, they look very similar to pink eye. They will have a strawberry tongue. So if you ask them to stick out their tongue, it's going to look like the surface of a strawberry. They also have rashes throughout their skin and then peeling of that skin, especially in skin folds, and cracked lips. So their lips are going to be very, very dry. Those are going to be your telltale signs. Like I said, we are diagnosing strictly based on what we're seeing visibly. Do you have any questions on that? That's the last thing that we have to cover. Okay. We will go ahead and move on to our Kahoot. I will let that load for you. Okay, we will go ahead and get started. Acute coryza is the medical term for our common cold. Signs of congenital heart disease are going to be all of those. We're going to see increased pulse and respirations as we're trying to circulate blood. We're going to see delayed growth because all of our nutrition goes to supporting our respiratory and cardiovascular system. We're going to have difficulty breathing or dizziness on standing, fatigue, and we're going to be at high risk for upper respiratory infections. Oxygen is carried by erythrocytes, which are our red blood cells. So they are responsible for carrying oxygen to our body. RSV is going to be spread through those droplets. So as they're sneezing or coughing, anything that it lands on is going to be at risk for spreading the infection. That's why hand hygiene is so important with RSV. Acute croup is laryngotracheobronchitis. So that inflammation in our larynx and our trachea is causing that stridor and that barking cough that we hear. Collapsed alveoli is atelectasis. Tachypnea is going to be increased respiration. So anything tachy is going to be faster. And then the apnea is related to our respiratory system. Our patients with cystic fibrosis need pancreatic enzymes to help them digest the nutrients that we see in their food. The child has a fever and an upper respiratory infection, we want to encourage those favorite fluids in small amounts so that we can keep them from getting dehydrated. We also can give Tylenol or ibuprofen to treat that fever. Remember to avoid aspirin. Lizzie, are you awake? Asthma can cause increased hospitalization. So as they're having more asthma exacerbations, they're going to be at risk for being hospitalized more. They're also going to have more doctor's visits. And it is one of the leading causes of school absenteeism. Common reason for pneumonia in infants is going to be respiratory syncytial virus or RSV. Which congenital cardiac defect causes increased pulmonary blood flow? So more blood flow going to the lungs. And those are going to be your ASDs, your VSDs, and your PDAs. Frequent swallowing after removing our tonsils and adenoids is going to be a sign of bleeding from our surgical site. Signs and symptoms of respiratory distress. We can have abnormal breath sounds. We can have increased breathing, and then also confusion from lack of oxygen. We're a little bit more generous with our pediatric patients because their lungs aren't fully developed. So we want their oxygen saturations to be above 90 to be considered normal. Three-month-old with cystic fibrosis wants to know how their child got the disease if neither parent has it. So in order to get cystic fibrosis, both parents would have to be carriers of the gene, and both parents would have had to give their copy for the child to end up with cystic fibrosis. For a child with asthma that is having fluid loss, we need them to have room temperature water. We don't want to give them anything cold that could cause their airway to spasm. We also want to avoid carbonated beverages because those aren't going to be rehydrating like we need them to be. The first 72 hours after a smoke inhalation injury is where the patient's going to be at greatest risk for that pulmonary edema, that swelling in response to the smoke inhalation. So with A coarctation, we expect the blood pressure below that kink to be lower. So we're gonna see lower blood pressures in our legs and high blood pressures in our arms. Let's do one more, guys. When we have cystic fibrosis, we need extra sodium because it all gets excreted through our sweat. And we need lots of protein because we can't digest fats. So protein is going to be our big source of energy. Okay, we are going to call it there. So it looks like Kay is our winner. Good job, guys.